Now I would like to request Dr. Shailesh Gaikwad and Dr. Harsh Rastogi to chair the session, please. Our next session is Flow Diverter. Mayday, we have a problem, technical innovation.
So we have a slight change in the schedule. There are two doctors online, live. Dr. Maria Martinez and Dr. Nasi Kochar have been waiting for a while, so we're going to take those talks first and then move on to the rest of the talks.
Hello, can you hear me?
Yeah, we can hear you, Dr. Mario. So we just give us 30 seconds to settle down. Dr. Mario, just we are running quite late, so I'd request you to keep your talks to 10 minutes each, if that's okay with you.
Okay, we'll try. So, good morning, everybody. First, thank you for the invitation. Thank you, Professor Gupta, for the invitation, and congratulations for this fantastic meeting. So I think I'm going to start with this talk, which is about the complication with this, in this case, with the pyramid shield. And so a device prolapse into the aneurysm is an underreported complication, is potentially devastating, and most of the times the case ends with arterial occlusion. Of course, this type of complication have the risk of thromboembolic and hemorrhagic complication. Excuse me, can you hear me well? Because I'm... Hello?
Yeah, we can hear you well. It's clear. Audio is clear.
Okay, thank you very much. So, flow diversion herniation can be intraprocedural or delayed. Most of the cases is because of foreshortening, and is this is because the design of the device, in this case, this is a pipeline. You see how the accordion effect foreshorten the device, and most of the cases happens, and this is called the watermelon phenomena when you make cases with arterial mismatch, and in case with tortuosity. So this type of foreshortening is not so infrequent with this type of devices. So it's important to mention there are different types of migration. There are proximal end migration and distal end migration. The distal end migration could call it like a benign type because it's more easier to get inside, get in access, and try to reposition the device. The problem is when you have the proximal end migration, we could call it malignant type. First, because it's not only the position only with because of the blood pressure, the flow diverter sometimes moves to a different position, and it is very difficult to regain access despite using different type of micro wires or the different shapes of the micro catheters. So I think you have actually you have a talk about the distal end herniation, I think, in the program. So I don't know if you want to go into. Could you confirm it, please?
There is a talk on distal end migration.
Okay, so I'm moving forward in this case. Okay. So I'm going to focus on the proximal end migration, which is called a malignant type. Let me show you a couple of cases about this technical management. You see this case is a PCOM large aneurysm. In this case, we select to treat the patient with a 4/18 pylon flex. We deploy, as we usually do it, we start the anchoring in M1 and then deploy it through the ICA. This is the deployment, was good. And at the end, with the navigation of the marksman, we felt like we have a little bit of foreshortening, but the device was stable. So we decided to remove the wire. And after the first run, that's what happened. The proximal end prolapsed completely here. You see in the aneurysm, and the prolapse was focused here in the inflow zone of the aneurysm. in this situation, which is could be, of course, dramatic, we try to navigate through the device again with different type. You can believe me. I mean, we try everything, all type of wires, all type of micro, everything, and we spent close to 4 hours, and we couldn't go into. So we decide, why not try to move this part of the device from the inflow zone or the outflow zone of the aneurysm. And the way to do is by inflating. We took a balloon, a 4x7 hyperflow balloon. We very gently inflated the balloon here between the aneurysm lateral wall and the device. And while inflating and pulling back the wire very gently, we move, as you see here, the device to an outflow position. In this point, we navigate a second micro wire in order to get access into the stem, and then we navigate it in a body fashion again with the balloon. So after getting this access, we inflate the balloon again at the level here you see on the neck, and pull back a little bit gently. You see here the balloon in place, and pull back here to position the stem close to the neck. And once we reposition the stem here in the neck, we navigate again with an exchange and navigate a maximum. And then you see here how the device, so for the beginning, it was an incorrect sizing. You see how short the device is right now, completely unconstrained. So we navigate again, and we did an exchange and telescope to more devices in order to be sure that we are completely covering all this segment, and did a complete arterial reconstruction. So this is, I think, it's a very interesting bailout strategy in this type of situation. And let me show you another. Well, actually, we already published this case report 2 years ago in GNIS. You have all the details here if you want to check it. And if you don't have the possibility to get in this the article, please send me an email, and I will send you all the details if you want have interest on it. And we have another, actually I have this complication 2 days ago, so I think it's very interesting. It's a very similar case. It's a giant cavernous case, partly thrombosed. So we started deployment, in this case was a pilum shield. The deployment was good, but we have a small stenosis. I think you may see here the stenosis here. So we tried to navigate the septal balloon in order to do an angioplasty, and because of that, we move all the device, we lose the access, as his was the situation. A proximal limb prolapse into the aneurysm. So we tried to navigate again, was almost impossible. So we continued doing a loop inside the aneurysm. In this case, it was very helpful to use the 90-degree session 10 with a synchro 14, then a transient 300, doing an exchange with the marksman. And in this point, we select to use solitaire 6x30 through the marksman into the loop, open it up distally, and then pull back the wire in order to reposition the stem. Okay, here remove the solitaire and then telescope the second device. So this is the case. We need to do the case transradially because the stem tortuosity was impossible to do the femoral. Here you see the ANVI 7/4" and the Navian 58/25. You see the lateral view, the 3D. This is the partially thrombosed segment. You see how is the tortuosity right here, and you see the mismatch diameter by comparing proximally to distally, which can be a cause also for herniation. This is the deployment. The device was very large. You see here, there's not a still opening from the beginning. At the end, it opens distally, but we have the stenosis at this point. It seemed like the length was correct, but because of that I mentioned, because of the try to navigate with the scepter, we move everything in. You see the position, and was impossible to keep the access in place. So this is, you see the yellow portion is the partially thrombosis part. We navigate through this partially thrombosis part, do a loop inside. You see here the lateral view, this is the echelon 90 degrees. We did all the loop. Then exchange as a marksman, open the solitaire as mentioned before, and then we remove all the morphology and telescope, a second device making a full construction. You see here how the full construction, fully opening in all segments, again, with this type of maneuvers. So to conclude, of course, it's better avoid than solve. In this giant or large aneurysm are challenging and usually associate arterial tortuosity. My tips to avoid migration, select larger devices, get a good anchor distally. It's very important to do a precise sizing, of course, the device selection. If you have a free device segment into the aneurysm, I recommend caution because coadjuvant balloons or posterior microcatheterization may tendency to foreshorten the device. If not sure about landing zone, it's better to telescope always a second device before losing access, and remember that the flow diverted unconstrained into a free lumen opens to nominal and promoting foreshortening accordion effect. In these cases of proximal herniation, of course, are more dangerous than the distal ones and should be avoided as much as possible. And in our experience, we need to do loop in all cases. And for undoing the loop and reposition, don't try it without distal anchoring. My recommendation, use a septal balloon or solitaire for undoing the loop. Thank you very much.
Thank you, Dr. Martinez. Excellent presentation. So, do you want to take question with regard to your first presentation? Is there any question from the audience? So, I think there are none. So, you can proceed with your second presentation, please.
Okay, so let's move on. Okay, the second presentation is about our experience. I don't know if you have available right now the shield, the pylon shield. Do you have pylon shield in India right now? Dr. Gupta, do you have the pylon shield available?
No, I don't think it is available as yet in India.
Okay. So just a quick remember, as you know, the device have three different evolutions. The last year in 2008, the first launching of the first generation of pipeline with the capture coil. Second generation, 2014, the device is exactly the same implant, same porosity, but with a different delivery system. You see here with these flaps, making the device receptable. And the last generation, the 3.0, is called the Pylon Shield. It's exactly the same delivery system than the Flex, exactly the same implant than the first generation, but with a surface modification to making the device more biocompatible, less thrombogenic. And it is made because of surface with phosphorocholin. And the fluoroscopy is exactly the same to recognize. You have the same markers that the Pylon Flex, so it's very easy to be confident if you have experience with the Pylon Flex. How else? Well, when you use a biomaterial inside the blood, you see here, for example, on a stem, the first step happening in seconds usually is the protein adhesion. After protein adhesion, they start the platelet activation, and then in hours, the leukocyte activation. And all these steps are mediated by thrombin. So thrombin is the main step here in the biomaterials associated thrombosis. What phosphorylcholine does, which is the main principle of the shield, is the ability to stop the protein adhesion, then stopping and blocking all the cascade, after all, of the coagulation and the thrombogenicity. You see here carefully.
Dr. Martinez, can I interrupt? We are not able to see your slides.
No?
No, sorry. Can you... you need to close the first PowerPoint and then open up the other one.
Sorry. Okay. Can you see my screen right now?
Yeah, we can see your screen now.
And you may please confirm me.
Yeah, we can see it right now, yeah.
Okay, so you didn't see any slide. Okay, this is the first slide talking about the devices, the evolution. You see here the first generation 2004, second generation 2014, with the new delivery system because of these flaps, as mentioned, and the surface modification of the third generation, which is called the Pylon Shield. This, as I mentioned, this is exactly the same under fluoroscopy, the same markers between Pylon Flex and Pylon Shield. This is the mechanism you see, as mentioned before. when you use a stent inside the blood. The first step is the protein adhesion, then platelet activation, then leukocyte activation, and everything is mediated by thrombin. What phosphorycholine does, which is the principle of the shield, is block this first step of protein adhesion, then blocking all the thrombin-associated thrombosis with these biomaterials. So here, this is the membrane of the red blood cells, and you see here the membrane is made of phospholipid, and the phosphorycholine is very similar to the polar head of this phospholipid, then making a complete coverage of the device with this phosphorycholine, which resemble the phospholipids theoretically, is less thromogenic, making the device not only less hydrophilic for a more hydrophilic fashion, also doing an irreversible adhesion of proteins. The device, in this sense, is more trackable and navigates better than the first generation and the second generation pipeline. You see here in this case, for example, this is small aneurysm, MCA, how easy navigates the pipeline shield despite not having a super distal intermediate catheter. What is the current status of the pipeline shield literature? Which is the global picture achieved during the last 3 years, have these just a few publications, some in vitro testing and some clinical studies. We published the results of the preliminary result of the PFLEX study. It was a prospective study of 50 patients. We published the last year the first result, and we are publishing during the next months the 1-year follow-up. We already finished the SHIELD clinical study, which was a very similar study, 2016, 200 patients, again, prospective, and we are planning the publication for the next years. As you see here, there have been in the last years some in vitro but interesting publication. This is the first publication by comparing the thrombin generation of the devices, and you see how the pipeline shield is significantly less thrombogenic by comparing with other competitors, first with Flex, first Shield, and it's very similar to the solitaire stent thrombogenicity. Another nice paper by comparing the platelet deposition. You see a comparison between FRED, first generation, and the pipeline shield, and you see how the pipeline shield has significantly less platelet deposition by comparing with the others. And by the OCT, it's very important to see that pipeline shield with this phosphorylcholine modification have less clot formation, and this has been confirmed by the OCT experience. I think Professor Demetrius Lopez had a lot of experience in this sense with the OCT, and he published this nice paper showing that not only the proportion of intimal hyperplasia, but you see here the difference between the pipeline flex and the pipeline shield at 25 days in this PICS model, and you see that beside the volume of intimal hyperplasia is quite similar, but with the pipeline shield is more homogeneous and more symmetric, showing that the device is more biocompatible than the previous generation. The clinical evidence I mentioned, this is our clinical trial, 50 patients, mainly females, and going forward. Most of the cases, 70% of the cases were less than 7 millimeters, most located in the ICA saccular within any case of basilar, distal bacillus. This is already published, it's open access last year in JNIS. The number of devices was significantly low, only 1 per device. And this is the most, from the technical point of view, the pipeline flex and pipeline flex with shield technology is very important to know that resheathing is very frequent. It's close between 24 and 40% of the cases, not only for delivery, also for open the device widely. You see here, we described this maneuver 4 years ago. Is the way to try to open much better the device. You see here the flaps, which are not visible on the fluoroscopy, and by resheathing the microcatheter inside the body, then you can invert flaps and the device open much better. This is very important, and we use it routinely to increase the wall position. Instead of doing a balloon, we try to do in this, and this is very, very helpful. You see here this lateral view of cardiothoracic aneurysm. You may see that the device is not fully open. You may recognize here the return point, and just by resheathing, you see how it opens, and you may have a complete wall position, see, with the resheathing. So after 30 days with the pipeline shield, our first experience was very good. We didn't have any major stroke and no neurological deficit. At 1 year, again, confirmed our results with no major stroke, no neurological death, and the complete occlusion was close to 82%, which is very similar to the recent results of 5 years PUFS study. We didn't have any recurrence, no retreatment. So just for learning and recommendations, for access, we recommend always use intermediate catheters. Depending on the position of the location of the aneurysm, of course, we recommend to navigate as much distal as possible. Where to start unsheathing, where to start the deployment. For PCOM and anterior choroidal aneurysm, we start to do it in M1 segment in all cases, and once the device open, we drag a little bit, and for more proximal aneurysms, we start at the landing zone where the aneurysm is located. The technique is exactly the same between flex and the pilum shield. Is 60% pulling microcatheter, 40% by pushing. The technique is like the same, all the flow diverters. You try to keep the micro in the middle of the vessel, which is very important, especially at the level of the course, where you need to play with the tension, pull the tension, push the wire, pull the tension, pull the wire, in order to do it very gently, try to adapt at the level of the course, the device, and open completely and achieve a good volar position at these points. It's very important to recognize that it's not only to the corpse with one device, but if you need to telescope the device. Well, first, let me tell you, for device selection, which is mandatory for avoid complications, we are using since more than 1 year this software, which is called the SimCure. It's a virtual stenting, and this is specifically designed for the pylon, you see, and you can change the diameter of the device, the length of the device, even the push for the technique, and you may predict the landing zone. And right now we are trusting more this software than the other type of software. So this is very useful for this type of devices. Okay, so by telescoping in corpse, this is a typical finding. You may see that the device is not fully opening. This is because of the tension that opening a larger device into a curve. In this case, it's not a device failure, so you need to continue with the deployment. And you may see that by continue the deployment, you see how the mid portion is widely open. And in this point, you need to continue pushing and making the device, you see how it opens more proximally, even more. And by continue pushing, you see this is the no return point. And then you may see they're going to open at the same time proximal and distally. Okay, so you see the device is open. Now you may navigate if you're not sure that you can make a balloon. But this is a typical finding. It happens a lot when you have tortuosity or you try to open the device into a curve. I mean, it's not a device failure. It's this type of morphology, okay? So to conclude about the pilum shield, of course, thromboembolic complications are the main problem with the flow divergence in general. The in vitro study have shown the pilum shield is less homogenic than the previous generation, and with the pilum flex study has corroborated the safety and efficacy of the pilum shield for the treatment of intracranial aneurysms. Thank you very much.
Thank you. Thank you, Dr. Martinez. Any questions from the audience?
Yeah. Marius, hi. You know, you use a lot of shield, and do you change your antiplatelets now?
No, we don't have the evidence yet to support it. I mean, we have the in vitro studies to support it, but it's very difficult ethically to justify to do it. Of course, we have cases with monoaspirin. We usually do it in Raptor cases. In Raptor cases, our protocol is 24 hours for Agrastat, and only aspirin as monotherapy, 300 milligrams. And until now, we have close to 10 cases with no ischemic events.
Right, thank you.
Thank you.
Thank you.
Thank you, Dr. Martinez. I'm Dr. Vipul Gupta. Thanks a lot for waiting for the while and for coordinating with us.
Thank you very much, and congratulations for the meeting.
Thank you.
So we move on to the next presentation by Nasi Kosar. He is going to present on retraction and gaping of overlap flow diameter.
Dr. Nazi, are you on?
To everyone. Thank you for your kind invitation. Thank you, Vipul, to inviting me again. I'm sorry not being in India this time. Are you seeing my slides?
Thanks a lot, Nazi. Yeah, we can see your slide now.
Okay. Let me start because of the time limitation. This is the topic, and first of all, I want to say something about that overlapping technique. When we first start scaffolding telescopic technique with cover stent intracranially, actually we created that technique by using the bare stent as a scaffolding stent, and then the shortest possible cover stent at the neck. And we apply this technique for the flow diversion. We have some problems during that period. Before showing the video case, I want to emphasize a very important segment of the cranium, that is A1, the fusiform aneurysm, is very important to deal with that type of overlapping techniques. This is the case, even though that the feeling part is small. When you look to lateral native images, you can see the calcified thrombosed portion of the aneurysm. What we did, at those time, our first aim to put the Leo as a scaffolding and I put the shortest possible silk at the neck. But the Leo slipped towards the ACOM, and then we can able to put the silk inside the Leo, come down to the A1 orifice. Everything looks okay. Everything looks stable immediately after deploying the stent. But what happened? This is the next day. Because of those cases, it is our routine protocol to check the stent morphology in the next day before sending the patient to home. As you see, the silk is slipped to the M1 segment. And even though we tried some manipulation, scenarios it out, they couldn't able to do it, and the situation is getting worsened because of the thrombose of the M1. What we did, we put an enterprise to squeeze the silk against the wall of the siphon tip and the M1 proximal segment. And this is the 3 months follow-up of that 3-stent mentality. Aneurysm is gone, and the Leo silk and the squeezing enterprise is there. So the putting the flow diverter in certain segment is not easy. And this segment A1 is always frightening me. And then we had a complication in India with the Fred Jr. case, one of the first Fred Jr. case last years. Come back to the real case that I want to show it to you with a video. This is a fusiform basilar aneurysm, and after having that flow diverter technology, of course we try to use it because it is easy to navigate, but there is no available flow diverter in such length. That's why we started to overlap the flow diverters. And this is the situation on slides, and I will show you the video. This is the first stent already deployed, and the second stent is coming down. And this is the end results of the second stent is flipped into the aneurysm site. You will see what happened. And this is the third one starting from here. This is the first stent. The third one starting from here, coming down to the vertebral artery. Second one is here. How it happened, you can see better now. How it happened, let me show you the video. First of all, we can start here. Now this is the manipulation, and then the catheter is in P1 segment. I want to make it faster for you, and this is not such important. The first stent is coming down. As you see, it is not enough. The length is not enough to cover all the aneurysm. And what we are doing, we are deploying the stent intentionally. We are aware that we already decided to put the second stent in it. As you see, it is going inside the fusiform aneurysm and then floating in. And you can be gentle and push the catheter inside it, but you can easily see the accordion effect on the fusiform aneurysm. As we listen Dr. Hans Henke's talk, the overlapping percentage, this is the point we decided to deploy the second stent. Actually, it is not bad. You know, you see the segment of the first stent, it is good enough. Let me go further. And then now, while you are deploying the second stent, this is the fault. What we did, let me do it again. What we did, while we are deploying the stent, as you see, we are taking whole the structures down to the arterial wall, and then the first stent is coming down. While deploying the second stent, look at this segment. It is good enough to cover. And then please look at, especially on the lateral view, what happened. This is the control run. Everything looks normal, but we give attention to the first and the second stent. That tension can pay back to you like this. See? It's ruptured. And what would you do? Of course, the first option is to take the second stent out. You can manipulate as you discussed this morning. But if it is not possible, what can you do? It is in the fusiform aneurysm. You can push the gapped stent in the fusiform segment, and then you can try to find the second stent orifice as I did here. And this is an old case. All the stents are Leo. After having such experience, I really haven't got such gap problems with the modern flow diverter technology, because we learn from those cases. First of all, second stent should be at least sized or oversized comparing the first one to get the radial force in the first stent. The second, you don't need to pull back the first stent to adapt the fusiform segment. You should let it down in the fusiform segment. Even you should let the stent struts touch the one wall of the fusiform segment. And then this is now the third stent is coming, and then the third stent is deploying without pulling back all the structures. Even nowadays, I'm pushing all the structures to touch the upper wall. Let me go for the other case to make you understand. This is another case, fusiform aneurysm. The fusiform segment is not large, of course, but as you see, and it is better to lay down and go over. There is another stent to get rid of the stenosis here, but this is the overlapping technology. This is 2014, and this is the 2017. It's almost gone. There is very tiny feeling of the aneurysm sac here. And then let me go another one like this. You can do this technique by knowing your material in your hand. And the radial force is very important. Flare ends facility is very important. And in the fusiform segment, the oversizing mentality is very important. And touching one wall of the fusiform segment is another important point. Altogether, this is the technical tips of that, the preventing that gapping or retraction of the flow diverter. Thank you for your attention.
Dr. Nazi, thanks a lot. And maybe we can continue with the next talk as well.
Sure.
Yeah. And then we
Thank
take the
you.
questions. That was a great presentation. Thanks.
Thank you very much. And thanks for giving me the opportunity to have the second talk. I don't want to use my friend's Dimitri's style in time. So, okay. this is the topic is the beyond the circle of Willis and the small arteries. This is my disclosures. After having proximal flow diverter experience, we enhance our indication to the distal aneurysm. But what I saw all around the world, people are trying to use the flow diverters for every cases. Even the circular one is the coilable one, or the balloon remodeling and coiling technique is much more useful than the flow diverter. But people think that the flow diverter is much easier than those type of things, especially in the distal vessels. We are certainly selecting our indication very properly. One of the very good indication for distal arteries is the fusiform aneurysm and some vessels arising from the aneurysm sac. And it is impossible or more risky to coil and the stent combination technique. We are using the flow diverter for those cases. This is the aneurysm, and this is the Fred Jr., and then it is just 4-month follow-up of the vaso-CT, and with a total occlusion in the patent side branch of this case. This is the year follow-up. See how smooth healing reactions in that segment without occluding of the tiny the frontal branch. This is my observation. If you have a proper technique and the proper material in the distal vessels, the occlusion time is a little bit shorter than the proximal aneurysm, maybe because of the aneurysms in that locations are smaller than the proximal aneurysm. And another case, the dissecting aneurysm, proximal portion has a stenosis, and this is immediately after stenting. You see the stagnation of the sac, and this is the position of the stent. As you see, proximal and distal end is properly opposed to the vessel wall. And this is a 9-month follow-up with DSA. See proper healing again without any intimal reactions in such tiny vessels. And another case in the bifurcation aneurysm, M1, M2 bifurcation aneurysm, as you see, you may try to do other technique, but even the VEP can be used in that case. It is kind of the mentality we should discuss in a long time. But this is my indication for bifurcation. Even in the circular one, if the one vessel's angle is not appropriate for use the stent, even we can do it. I'm trying to use the flow diverter in such cases, especially for young patients. This is only the 2nd month follow-up of the vaso-CT. As you see, the total eradication of the sac with the patent, the lower branch. This is a year follow-up. Again, most of the time we have such results. No intimal reactions, no delay filling of the covered branch. I also published the Fred Jr. paper, maybe you know, in the AGNR last summer, that we realized that even that smaller vessel flow diverter technology with the other published the group is not inferior than the proximal one, and it is better. This is a trifurcation aneurysm of the M1, M2, already clipped and regrowth. Again, the technique is here. This is the clipped, and this is the filling of the aneurysm. I'm choosing the largest possible vessels, and I'm looking at the angles of the vessels according to the inflow zone. And this is only 1 month follow-up. Just 1 month follow-up, you see the results. And so the size of the flow diverter and size of the microcatheter and the features of the flow diverter is very important to manipulate in such small vessels distally. And then as you see in that M2 upper branch has an aneurysm with vessels arising in the sac, you may stay here. This is a silk. It is also old case. You can come down and stop here without taking the risk of vasospasm, because that tiny silk also you are using 21 catheter, not the 27 catheter. You can stay just here, and then this is the follow-up with the total eradication of the sac. If with these complex cases, of course, you can coil it with the balloon and you can use a stent assistant technique. With such disease vessels, you can use the new technology. That new technology eliminates you go distally. You don't need to go distally for Fred Jr. because there is no distal opening problem. Whenever you deploy the Fred Jr., it is open in any vessels. I will show you much more tiny vessels, and because of there is no the wire in the stent while deploying, you just stop here. That means you're preventing manipulation distal. You're preventing vasospasm, dissecting complication, and you are layered down. And this is the case treated with pipeline. This is the chrome cobalt technology. And there's the baby portion of the aneurysm seen in the 3D. And this is the 1-year follow-up. What is the differences? The differences is here, the lower branch feeling. Even though the patient has no symptoms, time to time we have such results. This is the perfusion-weighted images showing clearly that the lower branch, the territory has less blood without symptoms. But that maybe because of those things, the new technology reduced the guide wire in the flow diverter to prevent such things. But it may happen. But we don't know what is the exact percentage of that complication, and we will try to accumulate all the things together, and in the next years we can see more. But what can we do in such complex aneurysm? It is already clipped and regrowth, and I could not able to go inside and go further in the upper branch. That's why I put again the Fred Jr., and this is after, and this is a year follow-up. This is the feeling part. You can see the old thrombose part of the aneurysm, and this is the 15-month follow-up with the nice results. Just only this segment, tiny segment is feeling, and that's it. And another complex aneurysm. Why we are talking about, we are not talking about the coiling, stenting, web, whatever. This complex aneurysm now became treatable. How can you treat this one? This is thrombose aneurysm, and the upper trunk has an aneurysm, lower trunk has an aneurysm. What should you do? And then what I did, actually, this is the feeling of the hemisphere. And then the most importantly, when you look this tiny part of the lower trunk, when I put my 21 headway, it is occluded. That means this vessel is around 0.7 millimeter. And even that 0.7 millimeter, you can open up the Fred Jr. And this is the Fred Jr. covered at the neck, and then come down and finish at the. This is not easy, guys. This is not easy to. You need to measure clearly. You need to understand that the elongation or the shortening of the stent. You need to know what kind of stent you are using. And I stop here at the bifurcation, and what you are expecting in such cases in the follow-up. Let's go. It is the 9 months follow-up. When you look to angiogram, the lower part of the sac is over, and the upper part is smaller. Let's go in details. This is the vaso-CT, intra-arterial. What happened to this vessel? This vessel is remodeled because of the flow. And in such cases, we should admire that flow diverter technology. Even that complex cases, we have a fantastic results like this. That means we should select our cases more elegantly, and we should not blame flow diverter too much, because there is no other option for this case. Even the surgery, the only options is occlusion of the sac and aneurysm and the bypass. Is it less risky? We should discuss. When you go back to the more distal aneurysm, M3, M4, such this, at those time we were using the pipeline. This is the 22.75 millimeter diameter pipeline. And you need to use that 27 catheter at those time. Now every company is working on that, the smaller profile of microcatheter with the smaller profile of the flow diverter. And this is the follow-up. The aneurysm is gone. Yes, all the flow diverters acting almost the same. I agree. Even the chrome cobalt, nitinol, whatever. But the problem is the radial force. Look at because of the radial force. It is not an adaptable stent. This is the pipe size, and this is the distal artery size. Even without any flow problems, it can, sometimes we're seeing such phenomena in the cardiac stenting. If you oversize your stent, it can be happen. And then let me show you the last case, and I will finish after. This is a case, again, in the same M3, M4 segment aneurysm, fusiform, already have an operation 8 years ago, and it is enlarged again with the thrombosed segment, of course. And then while I'm manipulating in, look at the complexity of the aneurysm. There is another vessels coming off, and you can see how I am manipulating in the aneurysm sac. There is a looping technique here, even such distal artery. And that distal artery is, when you look at the measurement, he is 1.1 millimeter. And then this is the arrival of the microcatheter in that segment, and this is the Fred Jr.'s opening. Really, it is only the 1 or 2 minutes to deploy it without any problem. And then this is immediately after, and this is the 5 days later of that case. And then you see the total eradication of that dissecting aneurysm and the patent distal artery. So what we are doing with the small arteries, we certainly enlarging our indication, but it doesn't mean that every bifurcation aneurysm should have a treatment with the flow diverter. It should be selected carefully to justify the science, because the surgery is also a good option for M1, M2 bifurcation. We can do almost every bifurcation aneurysm up to now by using this technique, and that's why the argument with open surgery and then the endovascular surgery now, and going down to the aneurysm with hematoma, and then the aneurysm of the case with sensitive to antiaggregant and anticoagulation. Just limitation to the surgery is appearing in the future. So the overall results up to now is promising, because the technology is helping us to lowering down the microcatheter, and then the lowering down the stent itself. It helps us to lowering our complication rate without changing our occlusion and treatment results. Thank you very much for your attention.
Thank you very much.
Professor Najib, thanks a lot. Terrific talks. I have one question. You showed a distal EC aneurysm with a stenosis associated with it at the proximal part of the artery.
Yes.
So what is the protocol? I mean, you are always sure the stent will open up there? You do a pre-angioplasty, post? What would you do?
And normally, you need to put your stent. I'm not doing angioplasty before it. As you know, before stent, performing angioplasty in such tiny vessels with a dissecting aneurysm may create problems. You may rupture, you may have a dissection, and you may not put the stent. Up to now, I really didn't do any angioplasty for distal flow diverter mentality, because I mostly use the Fred Jr. In the Fred group, there is the really less necessity to use the balloon angioplasty. Most of the stenosis is over after deploying the flow diverter.
All right. Thank you.
Welcome.
Okay. So, do you have any question from the audience? Yeah,
Okay.
please.
Yeah, Rajiv.
Hi, Nazi, this is Rajiv.
Hi,
Firstly, great,
how are you?
Good. So great presentation. I just wanted to tell you that first, thanks for giving us your template for the Fred. We've been accumulating our data also. So in India, we have done about 35 of these baby flow diverters using the Fred. And apart from that one case you mentioned, I don't think we have any mortalities. But the question I wanted to ask you was that, do you think the time has come to consider a larger flow diverter which doesn't have a distal wire like the Fred Jr.? Because if you remember Demetrius's case, which was shown a few minutes ago, The problem always sometimes, especially at the T, is that you don't want your wire poking around somewhere into a perforator or to the terminus or into another aneurysm. So it's also, though I understand it's limits the device technology, it makes it more stable to have a wire, but we should have a larger flow diverter without a distal wire.
Yes, this is very important technique. When I modified the Fred Junior from Fred, I decided not to put the guide wire because of the very small vessel indication. I don't want to put any wire in that distal artery. What distal artery is, most of the time the stability is not an issue. But especially for the tips, siphon tip and the basilar tip, in the angles of the siphon aneurysm, you need to have some stability. That stability actually, you can solve the stability issue by having a strong opening features with a good radial force. If you have an anchoring features of your stents in the open part, it helps you have a stability while manipulating down. In those mentality, you may reduce your guide wire length. Even you can put your guide wire length in the stand while deploying. As you know, the braiding technology, while you are deploying a guide wire, has a tendency to go up. There is also another technology, corkscrew technology in the guide wire. While deploying, the guide wire can be stable in whatever you put. But and other things, how soft should be, and then that softness is another issue. Some of the physicians like to have the softest guide wire because not to perform the endangering that the tiny lenticule or the thalamoparading arteries. But some of them has a more stronger supportive guide wire. That's why I think all the things is coming in the features, the opening issue, and also the anchoring issue. Nowadays, I'm working on that Alfred's mentality that alternating inner stent, because the new technology is coming. Two metal can be combined together as a single wire, and then we may have a better opening, better anchoring, better radial force distally, that we will get rid of the guided wire in the flow diverter.
Thank you, Nasir, for those wonderful comments. So we end this presentation now. Thank you very much from joining from Istanbul. And
thank you.
Hoping to see you later. Okay.
Thank you, and bye-bye. A good meeting all.
Hi, thanks a lot, everybody. And can I invite Dr. Khandelwal, Uday, Dr. Professor V.D. Sinha, and Dr. Gopal Raman Sharma to chair this session? And in terms of the sequence of the talks will continue, and it will be Shabil. There will be an awesome. Yeah.
And you can see the aneurysm on the MRI there related to this large aneurysm. So here we decided to occlude the aneurysm by using a flow diverter. And in France, there is only the pipeline which is reimbursed. So we took the pipeline, and so it's not a big deal. So it could be used. So I'm telling all of this because you will see during the procedure that it's really very important to understand the flow diverters and the radial force of the flow diverters when we are treating such kind of areas. So here, so my rule is when I have an aneurysm which is larger than 12 millimeters, I put coils inside the sac. Even I will put the flow diverter for two reasons. The first one, that the smallest aneurysm which was reported with the rupture after the flow diverter was 12 millimeters. So for me, when the aneurysm is 12 millimeter or more, I put coils inside the sac. Here we decided to put the pipeline regarding the neck of the aneurysm and to jail a microcatheter and to coil. So this was the 3D, and this was a technique. So the Navian, the 8 Frenchies, and the rebar, we see why the rebar, echelon 10 in the sac, pipeline, and marksman, so for the navigation. Here is the procedure. So, first of all, we navigated the microcatheter, so you can see here, so we tried at the beginning, this is not the beginning of the procedure, we tried at the beginning to navigate distally. We took the rebar 18 in order to navigate gently through the aneurysm and here. So there is one technique to rectify the catheter inside the aneurysm. It's to bring back the guide wire till the curve of the microcatheter inside the aneurysm and to pull it back. And like this you can rectify it without putting a stent, which costs 3,000 euros. And in the major part of the cases, so when you place the microcatheter distal, you bring the guide wire to the level of the curve inside the sac and you pull back over the microcatheter, you will rectify it alone. So you don't need to put stents or whatever inside. So once rectified, so we exchange with the Traxxas guide wire, and afterwards, so you can see here the guide wire getting up, exchanging to put the marksman here, and so you can see that the marksman was put distally, and afterwards we bring here the microcatheter and we place it inside the sac. So the rule here is when we place a microcatheter inside the sac and you want to make a jailing technique with the flow diverter, I recommend to make a loop inside the sac with the microcatheter that you placed. Like this, so you can coil in a safe way, because if you can pack better, much better, and second, so that your microcatheter is stable inside. Okay, so here we decided to go through. So here you can see the stent coming, and each time that we were bringing the stent, so here you can see, so each time we were arriving to the level of the angle here, so the stent was pushing the microcatheter inside the sac here. So this is the pipeline, you can see the guide wire of the pipeline. We tried, and each time you push the stent, so the stent is stiff, so this is a cobalt chromium stent, and the microcatheter was coming inside the sac. So this is why we decided again to place the microcatheter, and so you can see the rectification, how easy it is with the, and so we pulled back the microcatheter here to put a balloon. So, excuse me, oh, I don't want to damage, okay. So here we put the balloon, and the balloon was placed distally, not distally, so at the neck, and you can see the inflation of the balloon. So the balloon was kept turned inside the aneurysm, it's not a big deal, and we bring back the pipeline. And here the balloon attaches the microcatheter at the neck, and so you can push the pipeline again outside. You will see, so we'll start by deploying the pipeline, and once the pipeline is deployed on its distal tip, we can remove the balloon and put again the microcatheter inside the sac. And so always in the same shape by making a loop inside, and you can see the deployment here. You can see it better perhaps on the unsubtraction here. And so, in order to avoid the shortening and all of these things, so we have to know where we anchor the flow diverter. Sometimes it's short, but as you saw in the previous presentations, it's better to anchor it distally than proximally, so you can see how loose it is inside the sac. You can choose where to put it here. We were navigating again, so we were deploying the stand here. Yeah, you can see it here. And it's not mandatory to press in with the microcatheter again, so here we made it in order to make the massage inside, but so it's really not mandatory, and so afterward you put the coils inside the sac. While navigating, perhaps we put another stand here, perhaps we put another stand here. No, we made an angioplasty with the balloon downside because the proximal part of the stand was not totally open, and afterwards, so put coils inside the sac. So just this presentation to show you how we anchor, this was the question in the presentation, so to show you how we anchor the stent with the balloon, and so afterwards you go inside. And because of the loop inside the sac with the microcatheter, so we can pack it as you want. I will show you the final control. This is the final control. The portion of the sac, and so the pipeline deployed. So here we have, so this is why, this was the CT scan which was made before the inflation of the balloon that I showed you at the end. So we are really very, very attentive to this kind of thing. So when the stent is not totally apposited on the wall of the artery, even if it's in the middle of the stent, we make the angioplasty just to opposite well the stent along the wall of the artery, in order to avoid thromboembolic events and to increase the effect of the flow diversion. And this is the control after the procedure. Thank you.
Any short comment or question?
Thank you. Very elegant technique. Just also another technique that I use to avoid this herniation in the aneurysm is to bring the navion or whatever you use to the outflow of the aneurysm. And this is also, if you go with a microcatheter distally and bring it up, you can avoid using the balloon.
Yeah, I fully agree with you. It could be another solution, but here, so we were afraid that when we would bring the navion, it would make the same thing. When you arrive, this is combination, which was very tight, but it's a nice option.
And another comment, the same thing, but sometimes with those kind of aneurysms, wide neck, cavernous, or ophthalmic, while deploying the pipeline, you may run into the situation of herniating. This is why, while you're deploying it at the neck, I think unsheathing is key. You cannot push or anything. You're gonna mainly unsheath while you're at the neck, and then you can do whatever you want, because any push there, because of the vector force, will drive the whole pipeline in the aneurysm.
Yeah, so it's a key point, but we don't have to forget that we don't have to elongate the stent over the neck, so we can make what you are speaking about, the bridging technique, by putting back the stent when we are close to a large neck, but we don't have to elongate a lot the stent. So this is why at the beginning I was speaking about the interest of the cobalt chromium stent, because they have a larger radial force. So here, if you put a nitrile stent, whatever is a nitrile stent, so first of all, it doesn't have a radial force. Second, you are not sure that it's totally deployed because you don't see it completely. You are obliged to come back with the balloon inside, and when once you inflate the balloon, so you will shorten, so you will get a catastrophe.
I think you can continue your next presentation.
Okay. Yeah, we can go on to the next presentation. Oh. Retrograde balloon technique, collapsed proximal flow diverter, if you have one. then maybe we can have it later if that is so, or just to tell everybody, the dinner will be in the same place, and officially 7:30 onwards. I think they have written 8 p.m. onwards.
Right? Yeah.
All right. Huh? I think 8 is better here. So be here at 8. So we want to have a good time in evening as well.
I think we can call next speaker.
So this case belonged to my one of my fellows, so Marco Tullio. So because when you asked me for this presentation, I didn't have one like this, which is suitable in the department. So because probably because of the sizing of the stents or whatever, so we don't face this kind of proximal part stenosis with the stent. So Marco was proctoring this case in Brazil. So this is a female, 57 years old, chronic headache, and she has this aneurysm. So I think that in this case he used a Draco stent. So to cover this aneurysm, so you can see the aspect of the aneurysm here. You can see the 3D. He decided to deploy the stent without putting coils inside the cell. This is his material, so the Tricomax, the XT27, the transform, which will be used afterward, so the Delivo stent, which was 4.5, so which was, to my opinion, a bit undersized. This is the stent. So they navigated the microcatheter, they deployed the stent, and this was the end of their deployment. And you can see that the proximal part of the stent that you can see here, it's free inside the artery at the curve of the artery downside. And so once they so they made an engine control, and so on the engine control you can see how it's collapsed on the proximal part. Why? Because they arrived at the junction of the both segments of the artery on the curve of the artery here, and so the stent was collapsed. So they tried to go inside from the carotid artery, and they couldn't succeed. So here is the angiogram afterward, immediately. So and this is the second one is the angiogram that they made. Yeah, always immediately a lateral view. And the second one, so this is the aspect of the stent inside the artery. You can see how it's collapsed on the proximal artery here. So it's really very collapsed. This is a 3D that they made during the procedure. So they tried to go through it by the direct way, less than 10 minutes. So it was getting more collapsed. You know, the 19 it doesn't have radial force. And so if you have pressure on the outside of the stent, so you're going to collapse it more and more, and perhaps they had the starting of a thromboembolic events around the stent, so which is closing the stent here. So they started by, so 10 minutes later they made the angiogram. Over the angiogram you can see here that there is a stagnation over the MCA, and they were afraid of a thromboembolic event. So they were both of them in the operating room, and so the question was, so how could we do it, and how could we solve the problem? So they decided to put a balloon. So they checked the anterior communicating artery, and the anterior communicating artery was patent. I don't think that they had a full injection of both CDN artery, because we discussed about this case, and so this is why they didn't decide to occlude the left carotid artery. So they decided to go by the anterior communicating artery, but they were unable to access to the stent and to be stable with the balloon coming from outside. why they decided to keep the patient like this. And so the evolution wasn't big. So for me, I'm always afraid of that. So this gap between the stent and the wall of the artery, because here you will get a stagnation of the blood, and so you can get a clot migration distally. So this is why if we can avoid this situation, it's okay. So it's there. So for me, this case was managed by the inflation of the balloon, and they solved the problem of the patient. But look at this. So here, if you look to here, if the stent was a bit more distal, so they couldn't come back by the posterior communicating artery, and the only solution that they could get after what, if they couldn't occlude the carotid artery, is to pull back the stent. So this is what I wanted to present. Thank you.
Thank you very much. I don't think we have time for questions here. We may have to proceed to the...
So we move forward to next speaker, delayed migration and shortening of the flow diverter, Pascal Jabber.
So quick announcement, after this talk we break for lunch, but the lunch is strictly for half an hour. So by 1:45 we will be going to the live case.
Because the live case gets transmitted and that times cannot be changed, so it will have to be a short lunch. And Germany, Professor Henke says, center first, then one from Spain, then another from Germany. And some of the talks, mine and Raj talk, we'll see when they happen. Some of the talks will adjust in post-lunch session in between. We'll have time.
Okay.
Sharbil, are you the one to call whenever we're in trouble? So if you can put your phone number here so everyone can call you. This is my picture when I was in kindergarten or something. Where did you find that picture? So whenever we dissect a subject in detail, we're going to have a lot of redundancy and we're going to all be talking about the same thing. So as you know, this meeting is all about aneurysms and you're going to hear same techniques and same things, but bear with me. I'm going to be talking about delayed migration and shortening. We're going to start with the case. This is the case of this aneurysm that was treated with pipeline at 4.25 by 30. And as you see here in the M1, okay, the pipeline starts here all the way until here. So the case went well, and this is at the end of the case. Then the patient developed bad headaches, which we know it happens. So we got the CAT scan. The CAT scan looked fine. This was maybe 5 hours after the procedure. And we started seeing some thrombosis, and we see the pipeline here. The next day, the patient turned unresponsive suddenly. The patient was still in the ICU. And that's the CAT scan showing this massive hemorrhage. And we do an angiogram, and this is what happened. So the pipeline migrated all the way in the aneurysm and now directed all the flow into the dome of the aneurysm. You can even see where the aneurysm ruptured from. So unfortunately, the patient reconstruct the vessel. Yeah. Would anyone, at a delayed fashion, try to remove a pipeline? I think at a delayed fashion, once it's endothelialized and everything, you can do more harm than good by being aggressive and remove it. So in this case, we discussed all the options, and because the patient is asymptomatic, we got also an MRI showing no diffusion, hit nothing. We don't know when this happened. We're just gonna watch the patient. So for shortening of the pipeline, in this case, it shortened 1/3 of the original size. I think someone talked earlier about the watermelon seed effect. As you know, it happens when there's a mismatch with the inflow and the outflow. And what I mean by watermelon seed effect, if you take a watermelon seed and you squeeze it with your hand, it's going to jump and you're going to throw it far away. So this is practically what happens. The pipeline is going to be squeezed all the way in the aneurysm. Unfavorable wall opposition also has been incriminated in the proximal dislodgement of the pipeline. If you have, like a little bit like the case that Shadwell showed, if the end is close to the aneurysm and then there's no wall opposition with the blood flow, it can push the pipeline or the flow diverter in the aneurysm. Stretching or the accordion effect would move the pipeline toward the end that's better anchored. And I think what happened in the initial case that I showed you, we stretched this pipeline, despite the fact that we used a 30 length, but we stretched it, and the pipeline was anchored more proximally, so it had the accordion effect and then jumped in the aneurysm. Size mismatch is very important. And it's well known that if there's a significant difference in luminal diameter between the inflow and outflow, more than 1 millimeter, this can cause that. So the incidence of migration or shortening is around 3%. We published our paper. It's not something to brag about, our series of migration, but and then this is another case where it was a proximal M1 aneurysm where the pipeline migrated and then there was a thrombosis of the M1. Another case of migration. So mainly it happens distally. In 4 cases it was distal, but in 1 case it was proximal. So usually it's the distal that migrates. This is showing how much coverage the pipeline were covering before in the proximal and distal ends. Another case of delay. This is a case where the pipeline, the aneurysm was treated, and as you see here, at the end of the case, the pipeline was going all the way up to here, and then on follow-up, this is on follow-up angiogram, the pipeline just went directly, as you see here, in the aneurysm, as you see here. So we had to go in and bridge it, as you see, all the way, and the patient did well. This is interesting. I received a request, as you know, you receive requests to review papers. I received a request to review a paper on natural gas pipeline valve leakage rate, estimation via factor and cluster analysis. It's funny how sometimes there are like those programs that can match your name with the device, and they start sending all those requests. So what we need to do, obtaining a complete expansion of the pipeline with optimal vessel apposition. Accurate sizing is very important. Dyna CT may be useful, or expert CT. Using longer pipeline is important to prevent excessive foreshortening and to try to anchor it distal and proximal. Avoidance of dragging of the pipeline. Initially, when the pipeline came out, I used to recommend the dragging technique. This was with the classical pipeline, not the flex, where you would form the cigar, push it, then deploy it, then drag it. This can cause stretching of the pipeline. part of the device has migrated. This is more difficult. You're going to try to go with the J, go in it. If you can't, this may be a problem. At that time, you can go retrograde in the aneurysm like what Shelby showed. If the distal part is dislodged, that's much more easier. You can go and bridge it. Removal of the pipeline only if it happens acutely, not chronically. And the deconstructive procedure of the parent vessel, like we said, is a solution. Transcirculation pipeline, if you want to go from the other side, same thing. This is a case we published where we went through the ACOM and we deployed a pipeline retrograde. So I'm done. Practically, we're talking about foreshortening or elongation, so size matters, and you can see it here.
What you are seeing that in with the images, the angiography you get on the screen is
No, that was some testing going on.
You don't need to listen to understand. So size matters. Thank you.
Thanks a lot.
Thank,
And yeah, sorry.
thank you, Dr. Pascal, for excellent presentation.